I think mantle cell lymphoma is a highly aggressive disease, and patients with relapsed refractory disease have limited treatment options. BTK inhibitors have changed the space, and now CAR T cell therapy has also revolutionized the space, and we now need better understanding of how to sequence therapies. With the recent Triangle study, the role of BTK inhibitors is moving even more from earlier, although we need more longer follow-up data before this really changes practice. But I think we're seeing more sort of change in the treatment paradigm with BTK inhibitors being moved earlier, and the role of transplant now starting to be evaluated. CAR T cell therapy, in our studies showing in the real world population, the response rates are improved in earlier lines. So it's starting to, and the data looks really good in patients with relapsed refractory disease. So I think that's going to be increasingly used. I think the challenges that remain are continuing to figure out how to treat patients with relapse post BTK inhibitor and initial treatment and post CAR T. We need novel combinations of treatments to treat these patients with limited treatment options. And I think the remaining question is how does prior bendamustine affect treatment? Bendamustine is often used as part of induction therapy. In our study, we found that it didn't affect outcomes, but we need more data on manufacturing failures. There's been some data that prior benda can lead to manufacturing failure, and also timing of brenda prior to CAR infusion and how they may affect the outcome. So we need more data on that to better understand how to use bendamustine as part of induction treatment. So I think it's an exciting time in the disease space, but we still have a lot more work to do in terms of especially treating patients of relapse post these novel BTK inhibitors and CAR T therapy.